Hello, Benjamin Domb here from the American Hip Institute, presenting at the American Academy of Orthopedic Surgeons, or AAOS, in a debate on a 35-year-old female with borderline dysplasia and a labral tear with some acetabular cartilage wear. This debate was part of the AANA Specialty Day, in which I debated against Chris Larson from Twin City Orthopedics, who took the perspective of arthroscopy, and Stephanie Poon from Stanford University, who took the side of a PAO. My assignment was to argue to leave it alone until you put a hip replacement in it. So, over the last 2 decades, we've seen an explosion in the procedures that we can accomplish arthroscopically, labral repairs and capsular plications, and great treatment of FAI. And over that period of time, we've developed the ability to treat patient populations that previously had no real solution through arthroscopic means, including patients with borderline hip dysplasia. And by stabilizing them with capsular plications and labral preservations, in many cases have been able to achieve excellent outcomes and long-term preservation of their hips with a minimally invasive technique. Of course, I only had 4 minutes in this particular debate, and I intended to spend the majority of it disparaging my colleagues. So here we have my first opponent, Chris Larson, who said he can fix everything arthroscopically. And I submitted that if you scope a hip with borderline hip dysplasia and early osteoarthritis, you're going to have a bad time. If the process of degeneration has already started in a dysplastic hip, it may be difficult to halt it once it has begun. And what about periacetabular osteotomy? Here is Dr. Poon saying it's just a few cuts to the bone. Here you see Dr. Poon once again making a few of those cuts. PAO is an excellent operation for the right patient, but it does involve cutting the bones of the pelvis, and hence it incurs some significant healing and some significant risk factors. In previous literature, we've seen that osteoarthritis is correlated with higher failure rates of arthroscopy and increased rates of conversion for total hip replacement. No surprise. In our study, the second study here, which was a combined study between American Hip Institute and the Mayo Clinic, we looked at patients with a tonus angle of greater than 10 degrees and found 84% of them required a secondary operation. So put those two things together, dysplasia and early arthritis, and that is a potential bad prognosticator. And then in thinking about periacetabular osteotomy, or PAO, at least one study demonstrated a 7.1% rate of major complications. So, as we apply our intelligence to this, we start to think maybe there is a better solution if the patient truly has arthritic signs. Now, what are the excuses that my opponents may offer? Excuse number one, well, we are not burning any bridges. But is that really true? In our early follow-up of systematic review of the literature, we found that patient-reported outcomes were comparable for total hip replacement, whether or not a patient had had a previous hip arthroscopy. So that suggested that maybe we're not burning a bridge. But as we looked at our own data with midterm follow-up, we found that there actually were higher rates of complications and revision surgery for THA when there had been previous ipsilateral hip arthroscopy. So maybe we are burning some amount of bridges, and maybe there is a long-term consequence to doing a scope before a THA. Excuse number two, we will save your own hip for a couple of years. And that's great if it's true, but how successful is it really? And are we going to put them through a lot of pain and potentially wasted time and money in trying to preserve their hip in a setting where it really can't be preserved for very long? So, of course, as in everything, the indications are everything. Mild arthritis has to be characterized on X-rays and MRI or MR arthrogram, or in this case, a degeneric MRI, so that we can figure out who really has the beginnings of degeneration and who doesn't. And patient expectations must also be matched to the surgeon's expectations. If we're doing hip preserving surgeries like arthroscopy or PAO, we need to understand what are the limitations, and the surgeon and patient need to have the same understandings. So, in summary, some of the arguments against arthroscopy: it may be ineffective in borderline dysplasia with cartilage damage. It may not fully resolve pain or have higher failure rate in dysplasia cases. It may lead to THA later due to progressive wear, and it may require revision or additional procedures. And against the PAO, PAOs are a great operation for the right patient, like someone under 30, ideally, or someone who has moderate to severe dysplasia. And they may have longer and more painful recovery. The patient may still require THA later. If the cartilage is already worn, THA may be inevitable, and they may never have a 100% resumption of their functional status with a PAO. So that brings us to total hip replacement, arguably the best operation in the history of medicine. It has been described by the Lancet as the operation of the century, and perhaps is the holy grail of orthopedic surgery as we know it. At American Hip Institute, we have endeavored to take a good operation and make it even greater. And some of the things where we have focused our innovation have been on robotics and on outpatient THA. So when we do total hip replacement in this 35-year-old, this is a robotic outpatient procedure. The robotics allows us to eliminate outliers and eliminate the majority of human error and have a very accurate hip replacement, which is customized to that patient's own anatomy. And our minimally invasive approaches, especially the anterior approach, enable this to be a muscle-sparing procedure, which is an outpatient procedure with full weight bearing immediately, arguably a faster recovery than either a hip arthroscopy or a PAO. So in summary, there is only one GOAT, and in this case, it is the total hip arthroplasty for the 35-year-old with borderline hip dysplasia and arthritis. Thank you very much.